So there have been multiple biomarkers that have been evaluated and validated, including both markers of systemic inflammation and immune activation, such as interleukin-2, TNFR1, TIM3, IL-6 is just a few examples, as well as markers that are more closely tied to tissue damage, such as ST2, REG3 alpha, and amphoregulin. In the studies that we have done in the MAGIC Consortium and in collaboration with Shernon Holton from when she was at the University of Minnesota, now she's in Buffalo, we were able to show that the GI tissue damage biomarkers are more prognostic and more valuable in risk stratifying patients with GVHD than the markers of systemic inflammation and immune activation. ST2 and REG3 in combination perform very well, as does amphoregulin. And these biomarker algorithms have been used in clinical trials, several that have been conducted by the MAGIC group, and then another trial that was conducted at the University of Minnesota using amphoregulin to identify high-risk patients who were then treated with urinary derived human chorionic gonadotrophin factor, or UHCG, for healing. And in some retrospective analyses, we've seen that patients, the biomarkers can help identify who would respond to specific therapies, such as mesenchymal stromal cells or ruxolitinib. So the clinical applications with the biomarkers are that they can be used alone or together with clinical symptoms to identify patients who are likely to respond well to treatment and survive, and as well as the patients who are likely to not respond to treatment and die. And this allows us to treat patients according to their risk of success, treatment success or treatment failure. The patients who are likely to respond to treatment and do well are probably being overtreated, and the biomarkers are helping us identify those patients so that we can test treatment de-escalation strategies to avoid the toxicity of overtreatment. The patients who we can identify who are likely to have treatment failure and actually die from graft versus host disease, they're good candidates for treatment escalation strategies. And people are exploring a number of options to escalate therapy and improve the outcomes for patients who otherwise might die. I think the next breakthrough is going to be to identify an effective strategy. We're good at identifying the patients who are not going to do well, but we've yet to identify something that alters their outcome, their long-term outcome, survival. Even when response rates have been improved, we have not yet improved survival. I think we're on the verge of that with some new approaches, and hopefully what we'll see soon is that we'll be able to really apply this precision medicine approach where we can identify the patients who need more intensive therapy, and we will have the drugs that are effective for them and improve their long-term outcomes.